will continue with the Vesalius Symposium. I would like to introduce a good friend of mine, Dr. Pampana. I cannot say it. I'm so sorry. You pronounce your name.
Thank you so much. I'm Enrico Pampana from Rome, San Camillo Hospital. And it's a great honor and pleasure to be here. I thank the committee board of the Congress and the Vesalia staff, especially Diane, for involving me in this presentation. Where's the pointer, please? Pardon? Okay, thank you. Sorry. Please. So we point out now the NeVa device for thrombectomy with a new technology, the drop zone technology, new. Actually, they came in the market in 2018, and in Italy, unfortunately, we started using them in 2020, and in my facility now in the beginning of the end of 21. And I'm working in a neuroradiology department, and actually, I'm treating stroke nearly since 13 years now, and what really changed my way of facing these patients has been this paper in 2015 by the NESA registry, and I really thank this paper and Raul. They shown us for the first time actually how we should face these patients. It means that they shown for the first time that in 25% of a series of nearly 350 patients treated with solitaire, they reached a first pass effect, and they enhanced the fact that actually in this subgroup, the first pass effect was leading to a significant higher clinical outcome in these patients. It's a very significant difference between 61% and 35%, so it's really very important difference. So this is probably the paper that should have changed our way of facing these patients, because we have to focus on the first pass effect. Another thing that we already heard now in the previous presentation, which is really very important, what we know about the clots before treating our patients. Well, actually, we know, as told before, that there are different kind of clots, ranging from red blood cells to fibrin clots, with intermediate mixed compositions, but we don't really know what's the component of the clot before retrieving the clot. So now this is something that which probably is attiring our interest is evaluated, and there is a study ongoing now in Australia, led by Herr Rice, with this new Clotilde SmartWire guide system that it's trying. They will publish probably the results in the 2022. To try to know before the treatment what's the composition of the clot. Why this? Because actually, as seen before, the feature of the clot really changes the outcome of our treatment. We know that with a soft clot, we leave the stent river in place for variable time, and then we retrieve the stent and we succeed or not. With organized hard clot, this might be unsuccessful. And here comes NeVa design. It's a new design for the stent rivers. They started with 2 drop zones. Now they have some more different kind of stents depending from the size of the stent, with 3 drop zones also. And it's made by, as you see here, by these drop zones here within the stent. So it's made from meshes like the other stents, but these drop zones, they allow the clot to fall in the stent within, which is grabbed at the end by this closed distal tip that allows us to retrieve the whole clot and also smaller fragments. You see, the stent can retrieve the clots in both in the proximal part and in the intermediate part, or also in the distal part. You see in the last image a very, very fibrin composition clot. So these are the ranges of the stents of the NeVa stent. And it's important to focus and to choose the right stent for the right artery. So we will use a 4 mm by 22 for the distal arteries, and 4 by 5.5 or a 5.5 for the larger arteries. And these two final stents, they have 3 drop zones now. And an important thing is that probably if you see at the composition of the stent, you might think that, okay, there's less steel, less metal, so it probably has a lower radial force compared with the other stents. But actually, it has been demonstrated that if you compare the NeVa 5.5 with the Solitaire 6, actually the compressive radial force is dropping down quicker with the Solitaire in terms of Newton forces. So this is a point which is absolutely overpassed by the NeVa. And so they started in 2018 with the first animal lab results showing us that actually they succeeded in animal, of course, as they succeeded with the first pass attempt in both soft and hard, but also with ultra hard in 1 point, nearly 5 passes per attempt in onyx, so really stones. And this has been shown afterwards also by the group of Bajrami, of Marc Ribot, and with the first human study of 30 patients at the time, showing really slight important difference between the meta-analysis published in 2021 with percentages really significantly higher of first pass with this kind of device. And this is how it's working. It's very important. I mean, we are used to use standard stent reivers in which we know that we have to place the stent reiver in the middle with the thrombus, with the clot in the middle of the stent. With this stent, it's a little bit different. We have to overpass the clot with the 2/3 of the stents, and then slowly we retrieve the stent, and if we can't grab it because it's a fibrin clot, the clot falls in the stent itself and is grabbed and within the drop zone, the first, the second, or the third drop zone, and then it's retrieved like we see now in this. This is a video that has been shown by Diane when I went to Bajrami to see their in vitro model, and been really surprised. You see how the stents, this is an apple seed, how the stent itself can grab also an apple seed. It means so very hard, very slippery, but it's successful anyway. So now we still don't know which kind of clot we are facing, and probably in my experience, in my impression, my personal impression is that with this kind of stent, we can really face any kind of clot. I show you a couple of cases I performed this last month. The first one is an 81 years old lady with a MRS of 0. We faced the patient at 2.45 hours from onset with an NIH of 14, aspect 10. And what we visualized, it was a T occlusion, very strange actually, and with T occlusion involving the origin of the anterior cerebral and the middle cerebral arteries. So in our facility, I was absolutely a fan of aspiration from the beginning, and nowadays we are probably switching a little bit also on Solumbra, and this is after 2 passes with aspiration with Catalyst 6 and 2 passes with Trevo with aspiration, distal aspiration, and nothing has changed after 4 attempts. So what we did at this point, we tried with this, at the time it was probably our first or second attempt with the NeVa. It was really very simple to use it. And what we did, we placed probably not in the proper fashion the stent, but all thought after 1 pass with this NeVa 5.5, we succeeded after a first passage with this stent. And so this, of course, it wasn't the first attempt with this stent, but at the beginning we thought we could use the stent in case of failures of normal and classical stent reivers. The patient went well, went to NIH for 24 hours, CT scan was okay. we pointed out a tumor of the lung, and maybe it was a paraneoplastic clot. We don't know actually. But on day 9, after she arrived at NH1, before being discharged again, 18 aphasia, right hemi syndrome, and again CT and angio, another left occlusion. Sorry. Anyway, sorry, left occlusion again, a little bit more distal than previously, and again, here we have it. NeVa, first pass with NeVa, we succeeded with optimal revascularization after one pass with NeVa again. So this was a 4.5 NeVa, as it was, the occlusion was a little bit more distal. And again, it's important to choose the right device for the right vessel, but the patient died at after 5 days from treatment, actually. Another case, 67 years old gentleman, again half an hour from the onset, a very high NIH, another left arm occlusion, proximal occlusion. We went directly with NeVa, and I placed the NeVa. This was 4.5 NeVa. I thought I had placed the NeVa in the proper position if you consider the situation of the occlusion, but actually during the stent opening, I tried to check, because it was probably my second or third case, if we could have sort of bypass effect, but we didn't have actually a bypass effect, of course, but what I realized that probably I didn't place the stent properly. The mistake was probably that I didn't check with the distal angio till where the clot was arriving. But all thought the stent wasn't placed in the proper situation. After the first pass with the NeVa 4.5, I achieved a complete reorganization of the MCA, but as you see, I had a distal migration of the clot on the posterior superior branch of the MCA. So probably by IFU I should take a smaller stent, but we went more distal anyway with the same stent river, with the same NeVa 4.5, and we grabbed the clot in one attempt. So the impression is really very positive. Using this, for us, very new device. For other groups, of course, they are working with this device since nearly 4 years right now, and the patient went well. The take-home message from my short experience is that, of course, after the last years, we know that we have to look for first pass effect, actually. Is something we have to leave our old beliefs that we have to reach the revascularization with aspiration. You can aspirate as many times as you like, but we have to look for the first pass effect. And the drop zones of NeVa really came to us, allowing us to treat really any kind of clot, especially now that we don't know previously which kind of clot we are facing for. And till now, Dr. Bajrami now we show that there are huge experience with NeVa devices, and we will see incredible results. And we are now entering in an ongoing registry in Europe, I think also in US. Diana, correct me if it's wrong. And but we are very happy with this device. We see now wait for Dr. Bajrami experience. Thank you so much.
So hello everyone. I'm happy. Thank you, Dr. Pampana, for your beautiful presentation. After Dr. Pampana explained the features of NeVa, I'm just going to share with you our experience with NeVa since 2019. So we planned with Diane today that because we had a very successful NeVa case yesterday, we should drop the mic and not do a presentation at all, because we show that NeVa works very perfectly. So if it doesn't work, I'm just going to do that and go. But now I will explain our So we have a total of 145 patients included since 2019 with NeVa, with an age 69, with median age 69, median NH score of 16, median CT aspect of 9, and diffusion aspect of 8, with a mismatch volume of 69. So these patients included 60% of them MCM1 patients. Then the second highest was IC tip patients, and the third was MCM2. We had also AC A2 two patients and basilar 1 patient. So what we want to achieve and what everyone wants to achieve is the first pass effect, of course, and you want your device to retrieve the thrombus with only 1 pass. So what we observe with NeVa is that we have the first pass TK3 of 35 patients, 35% of the patients, and TK2C of 70.9% of the patient, which means that we have a total of TK2C3, which is the perfect recanalization of a total of 53.8 patients. And when we see the number of passes that we use for our patients, we always want to have 1 pass, the less pass you have, the less damage you do to the vessel, and the fastest your recanalization will be. So with the experience of NeVa, we have a medium of 1.8 passes, which means that we achieve recanalization mostly with 1 pass with this device. And the further observations show that even though our first pass TK2B3 is 77% with NeVa, our final TKB2B3 is 97.9 in this kind of patient, and the TK3, which is everyone's aim, is in the first pass as 35.9, but with the final TK3 of 60.7 patients at all. And the patient's NH score within 24 hours, the median NH score is 6. We will share with you in our data the MRS scores of the patient because our study is ongoing. So another observation that we had with NeVa is that we've been using this device since 2019. And as you know, with every new device, you need to learn the device tricks and learn the working mechanism. But you can see that from 2019 to 2021, our percentages did not change, which means that we have been using NeVa, but it does not have a very long learning curve. So you can easily learn how to use the device if you learn how to use the device, and you can show persistency in this kind of device with your patient's treatment, and this does not change with time. You can see that our TK2C3 changes just for 51 to 53, and our TK2B3 did not change statistically. And according to the time metrics, which are very important, we can share with you that we have our door to puncture mean time of 44 minutes and our puncture to recanalization of 25 minutes for this patient. And after you do stroke, you begin to like to take photos of clots. It's something that you are satisfied. And with NeVa, you can always take a good photograph with the thrombus well engaged at your device, which means a better recanalization, which means a first pass recanalization. And we just showed you a couple of patients which we had the recanalization. So in terms of complication and adverse event, we didn't notice any adverse event with this device in 145 patients, and we had a hemorrhagic transformation of about 29.7. So in conclusion, as I said, we always demonstrated that NeVa works perfectly, but the first thing that we notice with NeVa is that it can be applicable to every type of clot. It can have high rates of first pass recanalization, which is very important, and the most important thing is that you have a low average number of passes for your final recanalization, with which it would be very good for the patient's outcome, and still it has a favorable safety outcome. And as I mentioned before, we will have to publish our 90-day MRS scores. So we had a lot of cases. I will not just show a couple of cases. I just want to show the way that NeVa works with one case alone. This is an M1 occlusion, or right M1 occlusion, which was recanalized as TK3, and now in this recorded patient, you can see that after we access and we find that we have the M1 occlusion here. And after you catheterize the patient and you want to be sure that you have a J wire and catheterize the proper segment of the M2 branch, you then do your distal injection, as you see here. And then you want to place your device. So with NeVa, after you place your device, you have to be careful that you put the drop zones just distally to the occlusion. It will give you a better result. And in this case, after we placed the NeVa device, you can see here the displacement of the device. Then you will go with your aspiration catheter to do the thrombectomy. So it's not what we do in this case is that we go with our aspiration catheter over the thrombectomy device. You will see in a few, but that's not always an option or always possible. What we recommend is that you will start, as long as you use the devices, you will start to feel something in your hand. Your feeling will develop, and you will feel that you have your thrombus, and you will not need to go with the aspiration catheter, or on the adverse, you will not feel anything, and you will want to go with the aspiration catheter to achieve better recanalization. What we did here is we went with the aspiration catheter over the thrombectomy device, and we achieved the TK3 recanalization of this patient. So that's my presentation. Thank you, everyone. I don't know if we have a question or anything.